Okay, well, it looks like we have a number of folks joining us, so I think we can go ahead and get started. Welcome to the February Action Period call for the Smoke Free for Me project. We're very happy with the great work that you've been doing over the last month. We've been getting lots of data, and that has been awesome, so we want to thank you for that. Just a quick mention, I think you all know it takes a village for us to make this program successful, so we have some partners from the Ohio Department of Health and from the Government Resource Center joining us today, so we want to welcome them and thank you for all you do to support this work. Just a quick run-through of the agenda for today. We do have a lot to cover. We're going to just do a quick roll call and see who all is joining us. Sam is going to take us through a review of the initial monthly run charts that we have. And then Sam is also going to do a presentation on PDSA cycles. We'll do some reminders and have some time for some questions or comments from the sites. And we do have a wonderful success story that Dr. Lazaron, we wanted her to share with us toward the end, and then we will wrap things up. So with that, if we can just do a quick roll call. Do we have anyone on the line from Akron Children's Hospital?
Yes, this is Cindy from Akron Children's.
Great, thanks for joining us. And Cornerstone Pediatrics? Children's Medical Center, Middletown? I heard Dr. Hornick from Cleveland Clinic. Do we have anyone from Cleveland Clinic, Maine? Cleveland Clinic, Medina?
Yes, Christine from Cleveland Clinic, Medina is here.
Hi, Christine. Thanks for joining us.
You're welcome.
Do we have one from Stephanie Tubbs-Jones? I know I heard Tony joining us from Pediatric and Adolescent Practitioners.
Yes, and Dr. DeVerte is on her way.
Great, thank you. Eastgate Pediatrics. I think I see Dr. Long on the webinar. So we'll move on. Fairfield Primary Care Clinic.
Hi, I'm Jennifer Hardy.
Hi, Dr. Hardy. I think we have Dr. Warwick with us from Group Health Anderson.
Yes, you do.
Do we have anyone? Thanks for joining us. Do we have anyone from Ohio Pediatrics? The Christ Hospital?
Hi, you've got Elizabeth Lazaron here, and then Dr. Mattern, Dr. Eng, Dr. Hollis, and our nurse practitioner. Our nurse will be in the bit here shortly, and a few more people trailing in.
Great. Well, thank you for joining us. And then University Hospitals Medina.
Yes, this is Lisa, and Dr. Hummel should be in shortly.
Oh, great. Thank you. And then I know we have Dr. Hammond on the line from Wheeling Pediatrics.
Hello.
Welcome. All right, so with that, I'm just going to turn it over to Sam, who will be running through our first look at our aggregate run charts. Keep in mind that this is just a tiny bit of data from when you started the program through February 7th. In the future, we will be providing you with site-specific run charts, so you will get those actually before the next action period call, probably like right before, but you'll have those to review for site-specific, and just keep in mind that what you're going to be seeing now are going to be aggregate reports. So I'll turn it over to you, Sam.
Thanks, Kristen. So I do want to reiterate, too, that we can kind of think of this as like our baseline data. It was a run at how we could integrate these screening tools into each of your clinical settings, and then just using this as a frame of reference to start closing the gaps between what you currently see as our aggregate data that I'll be presenting and the goals that we've set that are displayed here on the key driver diagram underneath the SMART AIM on the left-hand side, where we're trying to incorporate the 5A screening intervention to 90% or more of the caregivers who screen positive for smoking, and that we're offering referrals to the Ohio Quit line for 90% of those who screen positive for smoking and vaping, and then also for 90% of those that screen positive and that are willing to quit and have resources provided to them. So threefold, we've broken those down into some additional measures to help gauge how we're doing with that progress. And we'll always come back to these SMART aims to see how we're using our key drivers and our interventions to get towards those goals that we've set out. The first of which, to kind of have all this be possible, is getting the screening tool into place. So what you're looking at on these run charts, and most of them are in the very similar fashion, the P is the percent of, or the proportion of tools that are meeting the required criteria, and I'm going to go through what some of that criteria is. So if it's not exactly where you think it should be, especially as we get further into this and you have your site-specific reports, you'll kind of know what needs to be met in terms of getting checked or addressed on the screening tool to help get towards that goal. And the goal is displayed in that green line. So all the charts moving forward, again, a very small sample of data from anything that was submitted basically within the first week of the collaborative is displayed as this first point on the chart. So what we're currently looking at, and you can also see the sample size for each of these charts, which will differ based on the patient population that the criteria defines. But here, screening tool uptake. So for all the well-child visits that you had with January 29th through February 7th, 80% of those well-child visits had a screening tool provided to them. So we're doing really good at starting off, hitting the ground running, and getting that screening tool into place. Just a little bit more to get close to the goal that we've set, and then to eventually 100% of those well-child visits getting that screening tool. The next one is kind of an aggregate of smoking cessation resources that are being provided to the families. And I have highlighted here caregivers. This is not only the primary caregiver who's actually attending the well-child visit, but also those caregivers who are other individuals within the home that may be smoking. So you can think of Measure 2 collectively. Anyone that interacts within that child's home that screens positive for smoking is receiving a resource from you as a provider. So when you look at the sample size here, we have about 35 individuals of those 219 tools that were provided to well-child visits within that first week who screened positive for smoking. And 70% of those individuals received a resource. And what counts as a resource? It's twofold. So because this is not only the provider that's at the well-child visit, but also other individuals in the home, there's a variety of ways that we can see who meets this, but it's advising and assisting the family. So you are discussing and selecting yes, that the MD discuss smoking with a caregiver or the other individual within the home, and you've provided a resource. So you need to discuss and give a resource to have this count for any individual that smokes within the home. So the individuals that qualify as this population are questions 10 and 11 on this screening tool. So the caregiver, do you currently smoke or vape inside or outside the baby's home? And then are there others that smoke or vape inside the baby's home? So we have about 70% of those individuals that are receiving not only the discussion, but also a smoking cessation resource. Then we break it down. So Measure 2A is looking for other smokers in the home. So of those other smokers, of which there were 32, about 75% of those individuals received those resources. And then this just breaks it down so you can see what makes up that measure. So our denominator here is the other individuals in the home. So anytime a family member selected yes when they did the screening tool, and then we are able to define those people as receiving a discussion and resource, so meeting our two qualification criteria to get at about 75% of those individuals receiving resources. Then similarly, we're looking at, and the line shifted a little bit here, but for smoking cessation resources for those family members that came to the actual visit. So mom or dad that's actually attending the visit, where we had 13 individuals that were mom or dad or someone at the office who screened positive for smoking, and just over 75% of those individuals had counseling, and received a resource. So very similar criteria as the other individuals in the home. We just want to make sure that we're not only talking about smoking with the family, but that we're providing a resource. So we can see within these measures, they're both very close to each other for other individuals as well as the individual that's presenting within the practice in terms of giving a discussion and smoking, providing a smoking cessation resource for that family member. So, but if we did start to see a little bit of a discrepancy or differentiation between those two, then that's somewhere that we could target our improvement efforts a little more specifically to help us get that overall global measure of providing smoking cessation resources and counseling to any individual that screens positive within that child's family. So then when we move on to measure 3, this is looking solely at the caregiver who is in office with the family, with that child for the well child visit birth through 1 year of age. So the percent of smoking caregivers who received the 5A's plan to quit. We had 13 individuals, again, because those are the number of caregivers who came to the office that screened positive for smoking. And you can see we have kind of 2 qualifying criteria, a check in place to make sure that those who answered yes, that they smoke or vape around the baby, that they're also noting, what they're actually smoking. So just kind of a check and double check in place to make sure that we're capturing correctly someone that's smoking. And of those individuals, we're bringing it up a level. So in the previous 2 measures, we wanted to make sure that anyone who screened positive for smoking had some counseling, had resources provided, but here we're taking that next step of arranging. So did the MD take that next step and have a referral, ask them if they wanted to have a referral sent to the quit line? And there are 2 ways that you can qualify for doing the appropriate steps for this measure, and that's checking yes, the family said they wanted to, and no, they declined. If you didn't try to offer the referral to the quit line, then that individual would not meet the criteria for having all the individuals hitting the smoking 5A's completed with that family member. And then this takes it one additional step. So of those caregivers who are willing and ready to make a change and have their information sent to the Ohio Quit line, of which there were 10, 50% of those individuals had that happen and accepted that offer. So very similar criteria here. We're looking at the patient population of, yes, they screen positive for smoking or vaping in the home. We had the double check in place to make sure that they noted what they're actually smoking or vaping. And then we wanted to see if they are ready and willing to quit, so having a score of 2 or above on question 17. And then for those individuals that meet that criteria, the caregiver discussed smoking, provided a resource, and the family accepted that. So it gives you, a step further. Here's for measure 3 that the doctor provided and offered a referral. Of those that had an offer and referral, these are the ones that accepted. And then our final measure moves away from the smoking cessation area but looks specifically at safe sleep resources. So the percent of caregivers who appropriately receive safe sleep resources. We had 71 individuals who had an unsafe sleep behavior, and that's looking at question 8 on your screening tool. So does your baby ever nap or sleep in any of the following ways? They could have had any or all of those items, but for whatever reason they selected yes. So of that patient population, did the MD discuss safe sleep behaviors? And the way that this is going to be calculated moving forward is if a family screens for unsafe sleep behaviors, did they then have a discussion with the family? So the physician will see the screening question is positive, ask the family, which one of these areas are you doing with the baby, and then discuss the appropriate safe sleep advice. So if it's location, making sure that they're sleeping in a crib, they would select that and then provide a safe sleep resource. You don't need to select all of them, but if it's warranted based on your discussion of what item the family has, then you would appropriately note all the items that you discussed with the family.
Can I cut in for a minute?
Yeah.
We have several families who will initially check that as yes, and when you talk to them further, this is not for bedtime. They're talking about, well, yes, sometimes the baby falls asleep while I'm holding him or while he's in his swing or something along those lines. So, that then needs clarified.
Again, so thanks for that point. I think that the issue at hand is this is just a screen, so you're asking the family, do they do this at every time? If they don't do one of those things, like their child falls asleep in the car seat, they are supposed to take that child and put them into their appropriate sleep area. So it's not only at midnight, it's for naps and other things, because you don't want the child napping in bed sleeping with mom. So if you find that there is that problem, then you ask them the questions and then you check that you had the appropriate discussion on the sheet.
Okay, that makes sense. Thanks.
I actually, for patients, no matter what they say for the sleeping, that's part of my talk with every patient at their checkup is say sleeping, whether they say yes or no. So I always mark those that I discuss it no matter what their answer is. Is that okay?
Yes, that's totally okay. I don't think that will influence the calculation, so you'll just see that come across a discussion. The only way we take it into account is if that individual screened positive and had yes. So it's okay to kind of note additional discussions that you may be having with families, even if they didn't have a positive screen.
Okay. I have a question also, when you're ready.
Yes.
So on the sleep thing, since we're doing this out to 1 year of age, a lot of kids sleep on their bellies after 6 months. So their position is not appropriate for your screening tool. So, so they on the front page fill it out so it's negative and they need a discussion. But when you discuss it, they're appropriately sleeping on their belly at that age.
So that's a good question. Interestingly, the AAP does recommend up until 1 year of age that you have back to sleep. Some will say that the true
if they roll over.
Oh, yeah, once they're rolling over, what are you supposed to do about it?
So it has nothing to do with the rolling over. It has to do with how you place the child to sleep.
Oh,
That's the question. So you're supposed to, up until the year of 1, you're supposed to put them on their back. You're supposed to put them in the crib. You're supposed to follow all those guidelines. Now, I will tell you that the true risk of SIDS is clearly between 0 and 6 months, but the AAP does have a recommendation up until 1. And again, this is really for you to have the discussion of appropriate safe sleep with the family.
Okay, so it's semantics. Okay, somewhat.
I mean, it's not complete semantics. It's this is how you're supposed to put your child to sleep. You're supposed to have this routine. And if a family isn't doing that, then it's worthwhile to have a discussion with them.
Hi, this is Kristen Schneider with Ohio Pediatrics. I just have one more thing with the sleep question.
Mm-hmm.
It says on the screening question, are they sleeping in anywhere other than a crib? And when we have newborns or 2-weekers, a lot of times they're in a bassinet, something like that. So the parents will mark yes, they're in a bassinet instead of a crib.
Has left.
So, do you want them marking that as yes, or?
That's a good question. Again, I think the answer is, could they be sleeping in a pack and play or another place? Yes. And so I would probably just check it and then have a discussion with them.
These are great questions. Are there any questions on any of the other measures that you want me to go back to? There is a measures table that was on the project homepage where you were directed where you could download additional resources and view the slides. So that information is there, but I'm happy to go back to any of the other measures to discuss if there are other questions as well.
Oh,
Ohio Peds again. I have a question on the referral for Pitline if it's a family member other than the primary caretaker.
Mm-hmm.
Is that a resource that's supposed to be handed out as well for the other household members, like even to the parent, for them to bring home the referral page for Pitline, or is that only like to be offered, and then if they want that referral for us to be doing in the office?
So in terms of the measure that's currently on the screen, this solely reflects the caregiver that's off because they have to sign off on that fax that's going to the Ohio Quit line. Outside of that, Kristen, any advice on the non-presenting caregiver?
So, yeah, I think we didn't want to burden you all with, having to refer a non-presenting smoker, and also because that referral, there's the signature part. But, I think it certainly would be great if someone is willing to send the quit line information home for the other party. So to send the pamphlet home, to highlight that they absolutely can call the quit line and get the process started themselves.
Okay, great. Thank you.
Any other questions on the data before we move to Plan, Do, Study, Act cycles?
Yeah, this is the Grace Hospital Group. One of the questions that we had that comes up persistently is we're completely unclear on that last question. Were all steps completed? If you have a patient who screens no for 8, no for 10, no for 11, and they don't require referral onward to the quit line, we've been putting down yes, that all the steps were completed, but does that mean it's supposed to be a no, the steps weren't required? And we've been a big scatter because nobody quite understood what we should say on those patients who are low risk for everything.
So the bottom part, what we currently have on the screen is the safe sleep on the bottom part of the provider. Let's see, do we have a full shot? Let me see if we have one of the.
No, it's the very bottom one. That's the bottom left.
Let's see. I think Kristen has it here.
Where all 5A's completed.
Mm-hmm. Let's see if it brings this up. Okay, this one right here. So what this does for us, we have some measures in place that help, check to meet. Did the family require a discussion? Did the other person require a discussion, and so on and so forth? So what you put here is more so for your kind of check and double check. If you feel that the family needed to have them done, you can say, yes, we went through the advise, assist, and arrange. If you did no, it's not going to ding you in any fashion, and you can interpret that as no based on there were positive screens and we just didn't do it. Or you can put in that comment section, no, family was no risk, did not require. And that can just kind of be for your record keeping. There are two kind of ways that this can be interpreted, given that you do have to do that first column with the nurse or MA or whoever else is grading the tool to indicate what risk that family member is at.
I've been just putting not applicable on the comments line in the ones that are all negative. Is that okay?
Yeah, that's totally fine.
This is Eastgate P.
Thank you.
My question is, if they mark no for 10 and 11, like there's no smokers, but then they turn the page and they add stuff to the other page that there are smokers, like somewhere in the home or whatever, like how does that get read when they're doing the data?
So we've tried to capture, let me go back to the measures that I have. If they answer that question 15, like the number of cigarettes that are smoked or vapes, to have that encapsulated there. But one of the things that may be part of your office flow and your data integrity check is as you're going through and grading the tool, double-checking question, if they do
if they do note on 15, yes, someone smokes, or there's a number of cigarettes that are smoked, going back to that question 11 and circling yes, and that'll help make sure that everything is pulled in appropriately. I realize that is an extra step, but if you are trying to figure out what needs to be discussed during that visit, hopefully it's not too much of a burden to kind of indicate that yes or no appropriately if the family member didn't do that question as it should have been answered.
So if a question was done wrong, we should circle the question? Like if the answer's wrong?
Kristen, how's that going to work with the Scantron? If they're doing it in pencil, it should be okay to erase and fill out, but I don't know how the markup may change if it's done with other ink.
Yeah, if you're doing it in pencil, it would be fine to erase and correct. If they've done it in pen, you would need to white out and then fill in the correct circle. So I think it is a good sort of process that if when whoever is scoring this takes a peek at that question 10 and 11 and sees, okay, I have a smoker, that you do a double check on that chart where they're writing in the number so that you're making sure that those are kind of consistent with one another. And if you happen to find an error there, if you can quickly, make that correction, I think that would be helpful.
Okay.
Anything else about the tool or data or walking through and interpreting any of the questions that families have answered or how you're documenting things on the provider section? Okay. If you do have any questions and you don't want to speak up, you can definitely put those questions in the questions and answer box and either send it out to the whole group or just the chairperson, which is Kristen or myself, and then we can either respond or answer those questions at the end of the presentation. So this next section is on Plan, Do, Study, Act cycles. So you left the learning session looking at your office flow and how you can take some of the barriers that Heather and Dr. Dritz had discussed and see how you can maybe circumvent and prevent those from happening. But then moving on to the next step, you've probably already done some of this informally, but taking and figuring out the best way to get the tool into place, how we can approach the 5 A's, giving resources, how to handle pass-off of the tool, if there are different people that are involved in the process. There's a whole lot of nuts and bolts that require some fine-tuning and testing, and that's really where PDSAs come into place. So it's taking ideas that you may have and properly testing them to make sure they result in improvement, that they are feasible for your practice, and that it really just makes this whole change process much easier, and you make and learn lessons and work towards sustainability. So taking ideas that you think are great, but you really do have to vet them and show that there's some evidence that they result in positive improvements, that they're really increasing your confidence that this is an appropriate change that you should be making, and that it's been refined, and as you're incrementally working on this, that you're having successful outcomes, so that you know as you're scaling this up that this change is really appropriate for you and or your unique clinical setting and patient population and providers that you're working with. There has to be some sort of flexibility in this. While you hopefully are having some sense of consistency as you work towards embedding this into your practice, knowing how to adapt this to your specific location, hospital, health department, to ensure that this specific test or change that you're working on is appropriately conducted for your local context. So while we have recommendations and interventions that we've suggested on the key driver diagram, really taking those and molding them to what your clinical setting is best suited for. And then identifying any side effects. So figuring out, what's that balancing component, reducing any risks or costs through your small-scale testing, evaluating the degree that this results in positive improvement, in addition to identifying any unintentional or unintended consequences, given that there's so many interconnected components within healthcare. And then the final component is really working to minimize any resistance. So allowing for anyone who may be affected by the change that you're doing to really be a part of the planning process, the discussion, testing the change, and really gaining ownership of the change so that they can not only be innovative, but also accountable in moving this forward. And then working to scale this up so that you can build upon the lessons that you've learned and scale it out to a larger and broader audience. So why do we test? It really is to force us to take a couple steps back from, this world peace aim of identifying all smokers within our clinical setting under 1 year of age and thinking how we can bite-size approach to working with any of those positive smokers after we screen for them. So thinking small, cycles of one, identifying things that we think are the best thing for our practice, that we have a high degree of belief in, and then taking those changes and seeing if they really work, building our confidence, and then moving forward with them. And then really using these PDSA cycles as an opportunity to learn, again, very small scale during one clinic afternoon with maybe just one of your providers on 2 or 3 patients so that you're not impacting the whole clinic and everyone that's involved and all the patients that walk through your door. Learning just enough so that you can take the information that you've learned, build upon it, scale it up just a bit, and adapt it to move forward to then broader audience and larger scale. And then it takes any ideas that you, if you're a solo provider working on this or if you're a team, and adapting them to any specific situation that you have within your setting. So just going back to the key driver diagram, there are a series of interventions that impact those key drivers on the middle of the key driver diagram, whether it's trying to figure out how to engage your core quality improvement team and getting everyone on board and on task with what their roles are within this project, how to utilize appropriate smoking cessation assessment and counseling, what to do with those people who screen positive that are willing to quit or who are not willing to quit. These are just a couple kind of bigger ideas that you can tackle to accomplish each of those key drivers. But there are certainly smaller steps that you can take and objectives that you can lay out for your PDSA cycles to help your learning. Again, so testing, seeing what works on a small scale within your environment, cycles of one clinic afternoon, one provider with 1 or 2 patients, learning what works or what doesn't work, and then testing with different patient populations. If you're doing this in a non-English speaking population, then maybe how you use an interpreter to screen if that's the route that you're trying to go, with different providers who may have different nurses that work with them, trying it over a wide range of conditions to work out any unintended consequences, any way that this could not work, and learn from that before you go to full-scale implementation and have this a part of your day-to-day operations. And then you build upon this to get to where you need to be with having some sort of smoking screen in your practice for birth through 1 year of age. So the purpose is not just for this collaborative to get the screening tool into place and screen for families and reduce smoking, but after the collaborative, that this is something that you have as part of your daily routine for well child visits, seeing what the risk of secondhand smoke is for any of those babies that are in your practice. So successive tests of change that build your knowledge, get you to have follow-up tests, more wide-scale tests, and then have that as part of your daily clinical practice. And it really moves us through a series of phases. So this is wave 1 of this collaborative. We're trying to do something a little bit innovative by screening our families and following up on referrals for those families to the Ohio Quit Line, having information sent to family members who are not at the well child visit. So we're really trying to take a change package, tools, the resources that you have, and learn from them. We're brainstorming together on these action period calls, hopefully within your core quality improvement teams, and coming up with plans for change. And then we're piloting those. You guys are testing these things out, testing and retesting, revising the way that you're approaching maybe how the tool is going out into your office flow, when you're going to give that, the front desk or your nursing staff gives it when you go back to the exam room, how you grade the tool, how the provider has a discussion, who gives the resources. You're figuring out the best way to do this. And then you eventually move to that green stage of implementing this and sharing how to do this with all the providers in your practice and all the patients that come in for a well-child visit birth through 1 year. So the PDSA cycle is the way to help you do that. There's 4 steps. There's the plan, do, study, and act. The plan is really just to lay out an objective. What are you trying to accomplish that helps you meet the global aim of this project? What's that one step that you can take on a very small scale to learn and move the needle towards those SMART aims that we hope to accomplish? And then based on that, are there any questions that you hope to address, and what do you think is going to happen as you do this test of change? And then just writing out a very brief plan about who's involved, what their role is, how this is going to happen, when it's going to happen, and what type of data you may collect to help come back and inform your next steps and to build that learning. After you've written out that plan, you actually go and do it. So you carry it out. Note anything that happened outside of kind of your X, Y, and Z of who's going to do what, when, and where, especially those things that were unexpected. So when you go to the third part of the PDSA cycle study, you can review not only any unexpected things that occurred outside of your plan, but also the data that you've collected. It certainly doesn't always have to be quantitative, like 3 out of 5 families got the tool. It could be something qualitative that you've noted about what worked, or maybe some family feedback that had been given. And then you can compare that data to what you thought was going to happen and figure out, what was the difference here and what resulted in that difference. How can we take what we observed and what happened and determine what our next steps are going to be? Are we going to keep doing how we initially started this plan, cycle out, forward with it, and modify something, or did the change that we decided to try out not work for us, and we need to try something totally new? So quick example, we have, and Heather had laid out prior to leaving.
All right, Sam, I don't want to interrupt you, but we're having a lot of background noise, so if you could just mute your phone if you're not speaking, that'd be great. Thank you.
Thanks, Kristen. So Heather had laid out a couple kind of concepts that could be targeted for each of the 3 PDSA worksheets that you have to submit. You certainly don't have to stick to these. Some of you have already submitted PDSAs. These are just kind of guidelines for helping if you're stuck trying to think of what you would like to do. But the first one that she had laid out was twofold. You could use the 5 A's intervention and target, what component of that can you work on and test and integrate into your practice.
Left.
Or how you can give resources to families that are identified positive for smoking or vaping. And thinking about one or those areas, what changes need to be made to help you get to the goal within either of those 2 areas. And really think of it as a mini experiment. You're laying out what your purpose is, what are you trying to accomplish. You have a little bit of information, and there's a reason you chose this change. You have some sort of confidence that this is an appropriate way, or belief that this is something that you should be doing. And make a hypothesis. What's your prediction about what you think is going to happen if you carry this out? And then you do the experiment, and that relates to the do section. You carry it out, you note your observations, and then go to an analysis. You kind of weed through what your observations were, any of the data that you collected, and summarize what had happened and make some conclusions. Is this an appropriate change to make? Is there something that we need to do differently? And again, if it's not something that's appropriate for the providers that are in your practice or the patients that you work with, abandoning that change. So starting off on the right foot. So you really want to first engage and empower your team. Hopefully, from the pre-work phone calls and the learning session, you have your core quality improvement team, or at least someone to help you with this effort, that really feels a sense of ownership about this. And I think those are really crucial components, that people feel that they have a say in what they're doing, that you guys can talk openly and brainstorm and feel comfortable to maybe do something out of the box, but that you have this team that you can work with. And then work on identifying a roadmap, putting that path through this collaborative together. In other quality improvement collaboratives, we do kind of a timeline. So we lay out the goals that we're trying to accomplish from the SMART aim, and then break it down for each month. What bite-sized change are you going to try and implement that may impact a specific key driver? It may affect, the use of the 5 A's or the screening tool if you're not getting that out to all your patients, but what is the appropriate path from A to B to C? And if you put your phone on hold, you might need to switch it to mute because we're having some background music. So putting that roadmap together that builds incrementally from the first lesson learned to the next, and highlights different tests of change that you can make that gets everything going. And it may be changes throughout the whole collaborative, or if you've already been doing some of this, fine-tuning those and figuring out how you can make this more sustainable and embed it for the long haul. And then always keeping in mind to start small. Don't overthink these things, very small cycles. You're doing one clinic afternoon with one provider and 1 or 2 patients, but you can learn from that before, moving out to the larger population and identifying anything that could be a drawback. And then always being prepared. Take those promising ideas and test them out, and doing so in a variety of conditions and settings to make sure that this really results in improvements. And keep thinking that this can go to the next level, how to scale it up to get to the goal. Really study and interpret the resulting outcomes, because this is really the time for learning and to build upon that learning so that when you get to implement, you feel that this is appropriate, you've had success, and that it's been done with relative stability. We have 2 tools that you can use. The one on the left has a more detailed way to kind of break down the planning of your PDSA cycle, what the objective is, noting different components of it. It very much mirrors what's on the right-hand side. The right-hand side has a couple more prompts to help you answer some of the questions that are displayed on the worksheet on the left. And then noting and having an observation section within do, and then studying, did your study match the predictions, comparing it to previous results and lessons learned, and then moving to that act step to determine where you're going to go with this test of change, what things are you going to take with you, what are you going to leave, and how are you going to move forward with any of the lessons learned. Those 2 worksheets are on your project homepage, so you have those available to download and then fill those out and submit those to us. Just a few PDSA pitfalls, the first of which is a vague PDSA objective. So compared to the aim of the overall project for smoke-free, each PDSA cycle has a distinct goal and learning that you hope to accomplish that will eventually impact our project aims. 2 is failing to ask learning questions. So if you don't have a hypothesis or a question that you hope will be answered by doing this PDSA cycle, like what will happen if we introduce the screening tools at the front desk, or how much will grading the tool in the exam room impact a nurse's or MA's workload, not having those questions really makes it hard to see why something may not have worked. So having something to compare against, especially in these first PDSA cycles, to see what worked or what didn't work and investigate why. Failing to execute the whole cycle. So within those worksheets, there's a section for each component of the PDSA cycle. If you're spending too much time on planning and that you never get to the do and study and act, or if you've planned it but then you're doing this for such a long period of time that you never have a moment to go back and evaluate what worked and what didn't work, you can't scale it up and get to the next step of your timeline and your roadmap. Your failures, fabulous failures, are a really good learning opportunity. They help you put fail-safes into place to prevent something from happening again, or knowing that something just isn't appropriate for the way that your clinical setting works or your institution works. So really taking opportunities to learn from those, changing direction, and trying something new. Lack of a detailed execution plan. So you do want to know who's responsible for what or how this is going to happen. It doesn't have to be very lots of information in it, but just enough that populates those worksheets so you know who's accountable and when this was going to happen, so you can refer back to see if everything happened the way it was supposed to, And if not, maybe that's one of the reasons why you didn't see as much improvement as you expected. Your data collection, again, quantitative or qualitative data. What type of data should your team be collecting to really help inform those learning questions and address the objectives of each of your PDSA cycles? And this data will be helpful to increase your confidence, not only of those in your core quality improvement team, but if there are other providers within your practice that you eventually hope to roll this out to, getting their buy-in to do this. So confidence in the changes that you're making, to gain that buy-in, to really evaluate the impact that your change efforts are having, and to help you determine what your next steps will be. And then the pitfall of confusing your task versus test. Tasks may be elements related to how you can do your PDSA cycle, like developing a screening tool like we've done for this collaborative, where tests are really figuring out what's the best way to put the screening tool into place and seeing how you can get that out to families. So making sure that your PDSA cycle is really a test and not a task. And then finally, PDSA cycles are for incremental learning and to build up and scale up on previous lessons. So as you do this first PDSA cycle, or as you're documenting your first PDSA cycle and putting together your roadmap, thinking ahead of what you're going to try and work on the next cycles over the coming months, over the course of this collaborative is going to be really helpful as you look at PDSAs as a whole. One of the components that's really helpful as you're trying to put something in for a sustainable fashion is evaluation. Evidence that changes that have been made, when and how they've made an impact, really thinking about this in terms of your roadmap, the resources that you have, and putting this together from the beginning so that you have a plan for the test of changes. Taking a step back and really laying out this plan so that you can be successful, not just in the short term, but once the collaborative is ended, and to really achieve any long-term outcomes that you hope to. So your plan should really help you monitor if particular objectives were met and how you were able to do so, figure out why certain innovations or tests of change may have been more successful than others, and if you could only do a few items to result in your level of improvement, what would those key factors and conditions be in order to be successful? So constructing a plan to monitor your achievement of objectives, why innovations were successful, and what made those successful is something that you can do as you put together that roadmap. You can identify, what resources you have, be it inputs or activities within your practice, what you hope to achieve, the impact of this, of course, your birth through 1 year of age, well-child visits, and what you hope to accomplish over the short term of, maybe just getting a screening tool into place, to eventually long-term having some sort of smoking screen in your practice that helps to evaluate any positive screens, to do 5As with families, and to give resources so that people are eventually quitting. So laying out your roadmap, engaging your core quality improvement team, and putting your plan, do, study, act cycles to help you achieve this. I mentioned that Heather had given you guys a couple ideas for potential PDSA topics as we go through this collaborative, the first of which was using the 5A's intervention, or how to give resources to families that did screen positive for smoking and vaping. That's just one or two of the things that you could do. Some of you have submitted on how you've gotten the tool into place within your practice, the best way to do that. Any and all topics are acceptable. But these are just kind of key ones. If you've gotten the tool into place, what the next steps can be. Your first PDSA cycle, however, is due March 7th, and then we've laid out when the next two are due by and other potential topics that you can use to target. With that, I'll open it up to any questions or comments that you have about PDSA cycles or tests of change that you guys have already done that you may like to share with the group about what's worked or what hasn't worked for you.
This is a question for Kristen, and I'm sorry to burden the group with this, but we had a very difficult time faxing our PDSA cycle to you. I just want to make sure that it was received.
And I'm sorry, I couldn't hear that. Kristen, could you hear the question?
I heard the question, but who is it that's asking that?
Ohio Peds.
Yes, I believe that we did get your, Kristen Howard, correct me if I'm wrong, but yes, we have been getting your faxes.
The PDSA cycle, did you have?
Yes, we did get your PDSA cycle.
Okay, thank you very much.
Yes, you're welcome.
Any other questions or comments?
Will the slide deck be available for view after this?
Yes, I will include the slide deck and some links and other information in my follow-up email to all of you. And then the recording of this call will also be on the program homepage. So if we don't have any questions, more questions about PDSA cycles, I'm just going to run through a few reminders. We've already touched on this today, but just in terms of remembering about grading the tool, you want to do those, quick double checks if someone has acknowledged smoking but has not filled in the chart with the amounts of smoking. Make sure that gets addressed. And just that initial left-hand column is the guide for whomever's smoking of those things to just double check. Also making sure that you are completely filling in the healthcare provider form. That's very important for our data reporting, so just a reminder to do that. We've mentioned the sleep screening question a bit, and so for the future, I won't get into too much detail about this, but as Sam went over, if it is a yes response to that quick screen, then you do have additional conversations. You figure out what the issues are with the safe sleep, counsel the family about those, and indicate which one, it could be one, it could be all that you've talked with them about, and then be sure that you provide that safe sleep resource and document that you've done those things on the healthcare provider form. And then just some overall reminders. Remember that with each screening tool, you do need to complete all pages. Don't forget to complete the provider data sheet that's at the end, and scan or fax all pages for data submission. Always make sure that you complete that cover sheet that has some very important information, in particular that last box that asks you to report to us sort of the denominator or how many well visits you had in the time period for the data that you're submitting. That's very important for the run charts. We've also mentioned today about correcting forms. It probably would be best to use pencil because you can erase. I think the concern is just making sure that it's the darker number 2 pencils. But if you do continue to have folks use ink pens, if there are corrections, those will need to be whited out and then the correct dot filled in. So you can make your choice what works best for your practice, but just keep in mind that crossing out, there's a problem with the data reading with that. So just try to keep that in mind for correcting forms. One thing we failed to mention early on is that it probably would be a good idea for you to keep these data sheets until the end of the collaborative. That way, if there are questions or concerns or something happens, you do still have the original data that you've sent to us. And then we had some questions about nicotine replacement therapy. There is a form on, and I don't know if I'm going to put that on here. There is a section of the Quitline referral form that asks you to sign to say if the person you're referring is appropriate for nicotine replacement therapy. We've checked with the Ohio Quitline, and that does not have to be completed by you, the pediatrician. So that will in no way impact the referral to the Quitline. You do not have to sign that or fill that out. If you do have additional questions about nicotine replacement therapy, let us know, and we're happy to provide resources for that information. And then I just wanted, Dr. Lazaron actually emailed us yesterday with a wonderful success story, and if you're still with us, Dr. Lazaron, or someone from the Christ Hospital, we'd really love it if you could share that with the group.
It was a success story from the very first week of the project. We had somebody who came in for their 1-week well child check, and the mom did not smoke, but her husband was smoking outside the home, trying to be careful about changing his smoking jacket before he then picked up the baby. And what we did is we went over they filled out the questionnaire in the Safe Sleep, and we gave them the information about caregivers smoking in the home and secondhand smoke, and then the third-hand smoke. And they came back for their 1-month well baby visit on Friday, and they saw that survey form and practically grabbed it out of our hands. We're so excited to fill it out because in the intervening months, the dad had met with his PCP, got started on Chantix, and was now a non-smoker, and they were so proud to fill that out and say that we were like a smoke-free family now, that it was like the most validating part of being part of the studies was just seeing this enable people to do what they knew was right in the first place. So we were really grateful, and it kind of gave new energy to the whole project to hear the story.
Yeah, so it was wonderful, I think, for us to hear, too, because that's just a reminder of, we may have a lot of those times where it doesn't work, but the one time that you see really the impact and on an infant so young and that it's going to continue on for their lifespan, I mean, that's exactly what motivates us all to be doing this. So I was really appreciative of you sharing that story with us. We've spread it around everywhere here, so I wanted to share it with everyone. And remind you that if you do have experiences and situations and anecdotes like that, please definitely shoot me a quick email and share those with us. The data is very important, but these personal experiences that you have with patients are equally important. So thank you for sharing that, and we look forward to hearing many, many more of those successes and stories. Just a quick reminder, and I will be sending out a calendar invite for our next monthly action period call. That will be on March 27th, same time, and we're working on getting someone from the Quit line to join us. A brief talk about what happens after you send them a referral and what kind of the process is and the services and the supports and that kind of thing. We'll also have our first sort of full month of data that we'll be reviewing. So please be sure to put that on your calendars, and I will send out all the information. And so I just we have just a couple of minutes left, but if there are additional questions or things that folks had, we'd love to hear those now.
Has left. Has left.
All right, well, just remember I'm here and available to help and support you in any way. So if you have ideas for future action period calls or topics that you think would be helpful as you do this work, please feel free to send me an email. Any questions or challenges or things that come up, also please give me an email. We're happy to do separate individual phone calls or site visits if needed to help support you. I will include in my follow-up email to you other opportunities that are coming up, some around adolescent health. We also have a spring education meeting that's coming up that we would love for some of you to join us for. One of the topics is going to be around smoking and SIDS, and we'd love to have some of the practices participating in Wave 1 of this project there to speak about your experiences and successes. So I'll include this information in my email to you.
Has left.